The session is first the PPT will go.
Good afternoon, everybody. I am Rahul Chobe from PHYSIO TV. We are live now for the today's webinar. I am handing over this session to Dr. Dinesh. Over to you, Dinesh.
Okay, thank you, sir. Good afternoon, all. I, Dr. Dinesh Chavan, Associate Professor at Sancheti College of Physiotherapy, welcome you all on today's webinar on key point of facilitation and introduction to Bobath concept. I'll welcome today our first panelist, Dr. Jui Dave ma'am. Madam is working as a now professor and HOD as a neurophysiotherapy department at Ternak Physiotherapy Colleges in Mumbai. Madam has done graduation and post-graduation from GS Medical College and KM Hospital, Mumbai University, and masters also from GS Medical College, KM Hospital, Mumbai University. Madam has done NDT courses, then specialization in SI and specialization in oromotor rehabilitation in cerebral palsy. Madam has done various advanced workshops of teaching technology and research methodology workshop. Madam has worked as a recognized PG teacher at MUHS, and Madam is a LIC chairperson member at MUHS. Madam is recognized PG guide at Rajiv Gandhi University of Health Sciences. Madam has invited member at the BOS Rajiv Gandhi University at Health Sciences. Madam has LIC chairperson member, Center Superintendent and Center Observer at Rajiv Gandhi University of Health Sciences. And Madam has various publications, national and international. I welcome you, ma'am, once again, Dr. Jui Dave, ma'am.
Thank you.
Thank you, ma'am. We have second panelist today, Dr. Manisha Deshpande, ma'am. Madam is working as a principal and professor at VSPM College of Physiotherapy at Nagpur. Madam is PhD scholar under MUHS and under KM Hospital, Mumbai. Madam has presented paper at national and international conferences. Madam was the keynote speaker at 7th World Conference on Physiotherapy and Rehabilitation 2019 at Abu Dhabi. Madam is MUHS Senate member. Madam has a publication, international and national publication. Madam is a journal reviewer for Journal of Education Technology in Health Sciences. And Madam is very interested in trekking and long distance cycling. Very happy to see Madam is the finisher 125 kilometer at Jaipur and finisher of 100 kilometer at Nagpur. I welcome once again Dr. Manisha Deshpande, ma'am. I'll request ma'am, please introduce our today's speaker, Dr. Gaurish.
Thank you, Dinesh, for the kind words. I am very happy to introduce today's dynamic and learned speaker, Dr. Gaurish Kenkre, who has an interest in neurological as well as musculoskeletal rehabilitation. Dr. Gaurish is a certified Bobath therapist from Western Cape Rehabilitation Center, South Africa, with an advanced training in Bobath concept from Porto Alegre, Brazil. He is also trained in motor learning concepts from Australia. He is a certified Mackenzie and Mulligan concept practitioner. He is a lead consultant therapist at Lilavati, Bridge Candy, and Fortis Hospital. Although into a clinical practice, he has a special interest in research and is associated with Bone Health Clinic of ICMR and also with IIT Indore. Dr. Gaurish, our audience is very eager to listen from you. You may start with the presentation. Thank you.
Thank you so much, ma'am, for the kind words. It's a pleasure to be on panel with you, and thank you very much for the introduction. I will start my PPT. Yeah, so I'm going to talk on key point facilitation and introduction to Bobath concept. So first of all, why am I here? I am not here to preach or teach anything new, but I am here just to share with you all my experiences and my learnings. Because neuro rehab, as we all know, is vast like ocean, and from my point of view, all of us are still learning. So this is my small attempt to clear some concepts in neuro rehab and to throw some light on Bobath approach, which has been traditionally practiced and always evolving in neuro rehab. So just to start with some history about the Bobath concept. So Bobath concept was introduced as early as in 1977. Concept was devised by Carol Bobath and Bertha Bobath. This concept started gaining so much of importance because it was one of the foremost concepts where the treatment was focused on the affected side. Because before Bobath concept, most of the concepts which are practiced in neuro rehab were on compensatory techniques using the unaffected side for functional independence. So in Bobath concept, they started using the affected side, started facilitating the affected side, started making use of that side for functional use, and that's how it started gaining importance in neuro rehabilitation. But if you see, the concept has evolved over time. So before, most of us know the Bobath concept as reflex inhibiting patterns, where we kind of block the synergy and then allow them to go out of synergy and make movements, reflex inhibiting patterns. But the name itself started giving a false impression about Bobath concept. Because if you have to inhibit something, that means there has to be a baseline tone in your body. And that started making news that the Bobath concept cannot be used in patients who are flaccid, who have no tone, completely flaccid. So that's why the concept name also evolved with time. So now it's no more called as reflex inhibiting patterns, but it's changed to tone influencing pattern. So now what does tone influencing pattern? So the tone influencing pattern means when a patient comes to you, you have to first know
Manisha ma'am, please mute.
So when a patient comes to you, you need to know what you are training. So if suppose you have to train an activity of standing, then what does it need? Standing needs more tone or less tone? So most of us know that the standing activity needs more tone. So we are going to give the patient exercises which are going to help build up tone in their body. Similarly, for an activity of release, if you need to release, it needs less tone. So you are going to give that patient exercises which are going to reduce the tone in the patient's body, and hence he will be able to release. So this is just an definition. So if you see these two gentlemen, they are trying to shake hands with each other. If you see them closely, if they really want to shake hands, they have to maintain a good posture. And that is something which is very important in Bobath concept. The first and foremost importance is given on postural control. That is what is the definition of the concept. It's a problem solving approach to the assessment and treatment of individuals with disturbances of function, movement, and postural control. So that postural control has to be underlined, and it plays a very, very important role in training patients using Bobath concept. Again, as we know, all our patients come with different demands, and that is why there is no structured set of exercises for every patient. You have to kind of be flexible. You have to adapt to the patient needs and kind of customize the exercises for every patient. So that's very important. And that's what we call functional training. So functional training is every patient has different functions, and you have to focus on that individual function when you are training. Again, a concept to be accepted worldwide we need to have some model which needs to support the concept, and the systems model is the model which supports the Bobath concept. So there is a constant interaction between the individual, the task given to the individual, and the environment. So when you're training, you need to use these three things in a manner which you can devise the exercises. So if you see this individual, the individual is the same, task given is also the same. What is changed is the environment in which he is walking. So he's been given a task of walking, one on the normal surface and one on a single bar of the parallel bar. So if you see the difference, he's so relaxed when he's walking on the normal surface. But if you see when he's on the parallel bar, his hands are automatically outstretched. We have not told him to outstretch his hands, but he is using his musculoskeletal system to balance. He is using his vision. It's not, his face is not seen, but you can imagine if he has to balance, he has to use his vision. He has to use his proprioceptive system. He has to make sure he doesn't fall. So when you constrain the environment, you get those automatic responses from the patient's body. That means what? When you increase the demand on the patient, automatically you get this sensory reorganization. And that's what is called as non-hierarchical self-organizing system, which is driven by multisensory inputs. So multisensory inputs include your proprioception, vision, your auditory system. You also later use your musculoskeletal system when you need to engage them, depending on the demands placed. Now the assessment. So every patient with the Bobath concept when you are training is assessed with the same concept of ICF. We follow the ICF model where you have to see the participation, restriction, activity limitation, and the underlying impairments. What it means is when a patient comes to you, you ask the patient or the patient's caregiver is what activities did the patient participate before the episode of stroke. For example, if the patient is a housewife, what does a housewife do mostly? Most of them say cooking. So then you ask the patient whether the patient is able to do that cooking activity now or no. So if she is not able to do cooking, that will come under her participation restriction. Why is she not able to do cooking? What activities you need to do when you're cooking? You need to stand close to a kitchen platform. You need to reach for your utensils. You need to grip a lot of things. So you ask the patient whether she is able to stand near the kitchen platform, whether she is able to reach, whether she is able to grasp. So if she is able to do, it will come under her activity. If she's unable to do, it will come under her activity limitations. And now why she is not able to do those activities is weakness, more tone, less tone, tightness. All these things will come under her underlying impairments. When you're treating, you go the reverse. You kind of target those underlying impairments. You target the tone. If there is less tone, you increase the tone. If there is more tone, you reduce the tone depending on the activities you are training. If there is tightness, you stretch. If there is myofascial tightness, you release. All these things are done so that the patient is able to do those activities which were limited and so that the patient is able to participate in their function. Okay. Now I'm going to talk about facilitation of the affected limbs in Bobath. But for facilitating the affected limbs, you need to know what happens in normals, because when a patient comes to you, his leg is paralyzed. And if you don't know what happens in normals, then you will not know the direction of facilitation, which direction you need to go. And that's why it's very important to know the normal movement. So what is normal movement? Normal movement may be considered as a skill which is acquired through learning for the purpose of achieving most efficient and economical movement or performance of a task which is specific to the individual, but most of the components are same in different individuals. So that's why there is an essential range of normal movement. So everybody, most of us, everybody in fact will eat in a particular manner. Everybody will comb in a particular manner. So that is a normal movement. So there is a range of slight differences, but most of us use the same components to do or move in a particular manner. And that's why we need to practice on normal subjects initially to know when you need to or learn facilitation in the affected individuals. So again, a normal movement, if you see, if I tell you to shake hands, the distal component is always going to start first, followed by the proximal component. Imagine shaking hands. But again, imagine a patient shaking hands with you. If you see, you can imagine a stroke patient, his proximal component will always start first, and then the distal will try following. You don't even reach for that shake hand, but it will start following later. So proximal starts first, and that's why it's very effortful. Again, the degree of freedom, it's the most important thing in training. Our shoulder has different ranges. It has abduction, goes around 180 degrees. It has flexion, goes around 180 degrees. So if you see, when I tell you to shake hands with me, the normal individual will control the degree of abduction. They will not go out, but they will come straight ahead. That's because you have a control over the degree of freedom of your movement. But imagine a patient shaking hands, trying to shake hands with you. They don't have control over the degree of freedom. And that's why what happens, they initially go into abduction and then they start coming ahead. So when you're training these individuals, it's very important to work on the degree of freedom also. Okay. Why the degree of freedom is important is because doing it once is okay. But if you tell a person to repeatedly do it, going into abduction, coming straight, going into abduction, coming straight, it's tiring. And that's why we learn the way it's more economical. And that's what is normal movement. Okay. So a normal movement is selective and sequenced. But if you see a abnormal movement, it's always slow, halting. You don't even reach the goal. Okay. And most of the normal movement, a large proportion is automatic. You don't have to think. You have to straighten your elbow. You have to flex your shoulder. Most of it is automatic. Whereas in patients, you need to actually think what needs to be done. And as a therapist, you need to give them verbal feedback. So they have a lot of cognitive involvement, which is required when you train a patient. Okay. So tone impairments, there are two main kinds of tone impairments. One is the less tone, which is the flaccidity, and more tone, which is the spasticity. And when you try and normalize this tone, it's called as tone influencing pattern. So tone influencing pattern, as I mentioned earlier, are the movements which help you to regulate or normalize your postural tone. And at the same time, they help you in eliciting active control of that same movement. So tone influencing pattern to increase. So there are some tone influencing patterns which will help you to increase the tone in flaccid patients. There are some tone influencing pattern which will help you to decrease the tone. So these are the things what we have been doing since years, but we have to know why we are doing it. Okay. So increasing tone, static weight bearing, we have been doing it always. Symmetrical bilateral patterns, joint compressions, symmetrical my videos will be seen. Yeah. So symmetrical bilateral pattern is something where you give a ball and tell them to bounce, 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 bounce. It helps you to build up the tone in the abdominal muscles. Joint compressions, we have been doing again since years. It can be in space for the shoulder. It can be in weight bearing, like bridging when you're doing, it's a joint compression happening at the knee. Okay. Quick movements. When you do quick movements, when you are bending and straightening the elbow and suddenly leaving the elbow, what happens is in prevention of the fall of the limb, you build up the tone. That's quick movement helps to increase the tone. Protective reaction. If I suddenly come and push you, in prevention of that fall, you will build up the tone in your body. And these things or techniques can be used to increase the tone in the patients who have less tone, or depending on the activity what you are training. Similarly, to decrease the tone, it's always important when a patient is spastic and tight, preparation is very important. You cannot directly go on tone impairments. You need to first prepare the limb. So you have to elongate and mobilize the fascia. You need to stretch the muscles. You need to release the neural tissue. and then come on the tonal impairments. The tonal impairments can be targeted by putting pressure on the tendon insertion, pressure on the bicep tendon insertion. You will feel the let go in the tone once you prepare the limb. Force, vibration and shaking, it's been a traditional method, again holding the limb and then just moving it in an AP and lateral directions to let go the tone. Rotation around the body axis, most important thing to which helps you to reduce the tone. It's called as a dissociation movement. If you ask a hemiplegic patient to turn, he will turn as a whole. They don't have dissociation. So that's why when you dissociate them, it helps in reducing the tone in the body. Wide range of movement. As we all know, synergies work in a small range of movement. And that's why when you go in wide range, you end up going out of the synergy and in turn breaking the tone. Movements with facilitation, which I'm going to describe few of those today. So what are these key points, what I'm talking about? So there are three main key points. One is the central key point, which is the thorax around T7. Shoulder girdle, your scapula and your shoulder joint. So thorax is the central key point. Your shoulder and the shoulder girdle, as well as hip and pelvis, are the proximal key points. Your hands, your fingers, your feet, your toes are your distal key points. And nowadays, elbows and knees are also considered as distal key points. Okay. So what do we do with these key points? We use these key points for facilitation. So what is facilitation? Facilitation just means to make a movement easy or make a movement possible. So what you do is you improve the postural alignment. You make a good postural set, means you place the patient in a very good starting position, and with your facilitation, you create a situation in which the movement has to take place. So it's very important to know is when you facilitate, you make sure it's not a passive movement happening, but you look for that automaticity when you are doing facilitation. That's very, very important. So you let it happen and allow movement to take place. Okay. So the next important thing is, what do we facilitate? So we facilitate using the key points, either the movement as a whole, or we facilitate the muscles which are responsible for that movement. So I'm going to tell in my practical demonstration how you use those muscles. So for a movement of rolling, either you facilitate rolling as a whole, or the muscles, like what muscle is used when you roll, it's the obliques. So you use the, either you use the movement or you use the oblique muscles for facilitating rolling. Okay, fine. So this is very important to know that when you facilitate the patient, the therapist hand needs to be soft, and it should not be an imposing hand which will passively do that movement. It has to be an automatic movement. That's very, very important. Okay. Yes. Now I'm going to just show a few demonstrations so that you understand the facilitations and key point concept. Yes. So again, coming back to the key point, if you see, this is the central key point, proximal key point, elbow and wrist is the distal key point for the upper limb. This is the proximal key point for the lower limb, distal key points for the lower limb. Okay. Now lie down. So what do we need to know in key points? We need to know how do the key points move in relation to each other. This fan needs to be. Distal key point, if she is attempting a movement of hip-knee flexion, how does the distal key point move in relation to the proximal and central key point? And how does a proximal key point move in relation to the central key point? So if she is doing a movement of hip-knee flexion, what happens? Where is the distal key point moving? Whether it's moving towards the proximal, whether it's moving away from the proximal. That's very important. So what's happening? It's very easy. It's moving towards the proximal and towards the central. What is happening with the proximal key point. It is moving towards the central. But if you see closely, it is not just a towards movement, because your normal alignment of the leg is in external rotation. So when you move, you first align the leg inside and then you move towards the proximal and central. So these small observations are very important, and that's why I told you need to practice on normal individuals before you practice on patient. So the distal key point initially moves slightly inside and then it starts moving towards the proximal and central key point. So when you are facilitating, you have to make sure you do that small inside movement and then you start pushing towards the proximal key point. So now while facilitating hip knee flexion, what you need to do, hold the distal key point, hold the proximal key point, and just push the distal key point in and towards the proximal, and push the proximal key point towards the central key point. That's the facilitation for hip knee flexion. See, so it has to be an automatic movement when you do facilitation. It should not be a passive movement. Should not be a passive movement. You have to look for an automatic knee bend. That's very important. Okay. Now, when is the hip knee flexion required? It is in lying down. Hip knee flexion is mainly required when you are rolling on one side, right? So if I have to facilitate hip knee flexion, most of the times you need it when you are rolling. So when you are rolling, what you can do is, if the lower limb is the more involved limb, you ask the patient to hold her hands like this. You will have to make sure the environment plays a role. As I told you about the systems model, the patient is on this edge so that she doesn't feel scared and she doesn't resist your facilitation. Now in this position, why I have held the hand like this is because most of the patients, if you see, their hand is in ulnar deviation when they have tone. So this will help you to block the ulnar deviation. And now if I facilitate, relax and roll. Okay? Facilitate and roll. This is rolling, facilitation for rolling using key points. Let's come to the second most important key point facilitation is bridging. If you consider bridging, what happens in bridging with the key points? Distal key point ankle is fixed. Distal key point knee. What will happen? Think. What will happen when you bridge? Will it go away or will it go towards the proximal and central? It will go away from the proximal key point. It will go away from the central key point. So the distal key point is moving away from the proximal and central. And what is happening with the proximal key point? Again, think. Bridging is an activity of what? Back extension or hip extension? When you are training, bridging is an activity of hip extension, not back extension. So for hip extension to happen, your pelvis needs to tilt posteriorly. Very important. So if your pelvis is tilting posteriorly, what is happening with the proximal key point? It is moving towards the central key point. Okay, so the proximal key point is moving towards the central key point. Distal key point is moving away from the proximal and central key point. So when you are facilitating bridging, you have to fix the distal key point, pull the proximal distal key point away from the proximal key point if you consider knee as the distal key point. One more thing I mentioned in facilitation, you either facilitate the movement or you facilitate the muscles which are used for that movement. So bridging, hip extension, what muscle is used for hip extension? It is the gluteus. Gluteus is a large muscle, and if it's a large muscle, if you just pull her away like this, the muscle will not get engaged, and that's why you need to engage the muscle. And it's a concentric movement. When you need to engage the muscle, you need to push towards the origin. So this is how you facilitate bridging. Hold the distal key point like this, one hand on the glutes. While pulling the distal key point away from the proximal, you push the glutes towards the origin. This is the bridging movement. Okay. So that's the facilitation of bridging. Let's come to one upper limb facilitation. Sit. How much time do I have? So forward reach. If we consider forward reach, what happens and how do we move when you do a forward reach? Distal key point is moving away from the proximal, away from the central key point. What is happening to the proximal key point? Proximal key point, if you see, is moving towards the central key point. But again, those key observations. If the proximal key point just moves towards the central key point, she will not be able to clear her hand or arm from her trunk. So there is a very slight outward movement of the proximal key point, and then it starts moving towards the central key point. And when you are facilitating, this small little observation is very important when you facilitate. And that's why when you facilitate, you hold the arm close to the proximal key point. With your fingers, you pull the proximal key point slightly away and then push it towards the central key point. So this is the guiding hand. This is the facilitating hand. You pull it away and you pull it towards the central key point. Away and towards the central key point. Away and towards the central key point. Lot of patients ask, a lot of therapists in my workshops ask me, you will dislocate the shoulder when you are doing this, the shoulder is subluxated. So what I am telling you is, this is just a menu. It's not for you to choose. It is up to you which movement to choose or which facilitation to choose when you are treating the patients. So you need to just know the facilitation techniques, but what needs to be done in which patient, that is your assessment skills, and that will come with your experience. Fine. So I'm going to show a few videos now. Hip knee flexion. This is a different one. Okay. So you need to know when to build up tone and when to reduce the tone. Now she is trying to lift up a bottle. So lifting a bottle up needs to build up the tone. You need to build up the tone in her body. So you give her some object which is with weight, and you give her some overhead activity which is going to help her build tone in her limb. Again, you have to work on the principle of motor control. Lot of repetitions is important. We are trying to build up the tone in her upper limb, and after building up the tone, if you see, she is, I think Julia was there during this workshop.
Gaurish sir, it was not visible.
Gaurish, the video is not visible.
Video is not visible. Okay,
No,
1 minute.
no.
Now is it visible?
Yes, now it's visible.
Is it coming now?
Yes.
So she is trying to lift a bottle. Lifting a bottle needs more tone in your body. So you need to build up the tone in the upper limb. So we gave her activity with some weighted object like a skate because she can slide it and go overhead. Going overhead itself builds up the tone.
Very good.
So a lot of repetitions is important because Same principle of motor control. Post treatment, if you see, she is able to lift the bottle immediately. Just give me 2 minutes. I just need to show some more videos. This is visible, Dinesh? Voice.
Yeah,
Yes,
it's
sir.
visible.
This is hip knee flexion facilitation. He is trying to do hip knee flexion. Putting so much effort. So we have to engage the patient actively also. And if you see immediately post facilitation, he is able to initiate the hip knee flexion. Stop. Is this visible, Dinesh?
Yes, sir.
Yeah. So this is a patient in one of our camps. He is again trying to reach overhead. As I mentioned in the earlier video, reaching overhead needs more tone in your body. You need to build up tone. So which is one of the muscles which helps you to build up tone. Biceps is one of the muscles which has tone. So we gave him a repeated activity of the biceps because it is easier to build up tone in biceps. And then if you see immediately, he lifts his hand slightly more up. This is immediately in a single session, just to tell them that they can improve. That's it. That one video will show. One last video of one patient who used to treat in a municipal hospital. This is again a spinal surgery patient, scoliosis correction. So again, standing and walking needs more tone. We gave her a lot of activities, symmetrical bilateral pattern, facilitating using key points. We could achieve quite a bit environmental training also. Just to tell you that neuro rehab can work wonders. We can really achieve a lot of things just with exercises. Exercises in the right manner. Yes. That is it from my end. Dinesh, we have any questions?
No, sir. Now we don't have question in chat box. So I'll request panelists have the questions.
Thank you, Dinesh. Manisha ma'am, may I start?
Please, Zoe, go ahead.
Okay. Thank you, Gaurish, for that lovely, fluid presentation. As always, I've had the pleasure of hearing or listening to you earlier as well. Um, just to initiate the discussion, we do emphasize a lot on the repetitions and the practice component of each movement. Till date, there are conflicting arguments about how many repetitions are optimal uh, to bring about a change. So what's your opinion on it, or what does the Bobath uh, say about it?
Yeah, so the Bobath concept has also evolved with that point of view. So we also encourage a lot of repetitions. Ideally, we need to tell patients to reach as close as 4,500 repetitions.
Right.
But we normally in our therapy sessions ask them to reach at least around 900 in a day. Bobath, with facilitations, you are going to achieve a sensory activation because initially in that paralytic stage, what happens is the descending tracts are not functioning, motor power is not there. So the
Mm.
only way to communicate with the brain is with sensations and sensory
Mm.
stimulus. So you look for a response using facilitation techniques. But once the
Mm-hmm.
response starts coming, yes, repetitions are important. And the evidence says that you need to actually go for that around 4,500
Yes.
actually achieve a good specific isolated movement.
Okay, okay. I had another, not a query, but your opinion or your view on NDT, which sometimes is considered as an extension of Bobath, is sometimes considered as a alternative to Bobath. There are a lot of therapists out there who are practicing NDT, and So, what's your opinion on the utility or the integration of these two approaches, or what works best according to you?
Yeah. So a lot of concepts in Bobath and NDT are work on a similar line. Actually, there are just these two bodies which are different. NDT is more evidence based from the time it started. Bobath initially was not much evidence based, but now they are working a lot towards research and evidence and publications.
Mm-hmm.
Most of the things in Bobath schools and NDT nowadays have been on a similar pattern.
Mm.
Everybody is working towards motor control once you
Mm.
facilitate. So
Mm.
I am been part of the IBETA, I'm been associated with some
Mm.
IBETA instructors. So
Mm.
when we talk to them, they say that NDT and IBETA are mainly two different bodies, but
Mm.
instructors, a lot of them have an overlap in the instructors.
No, why I'm asking you specifically, I'm asking from an academician's point of view. We do train students where, there are, we present them as different schools of thought, or rather, that's how it's defined in the syllabus, as two different schools of thought. So one is different than the other, and one has different evidences than the other. So many a times as a teacher, it gets very difficult to convince them that, at the end, it's like, all roads lead to Rome kind of a thing, that at the end, it is that you are working on motor control. And it's just a way of looking at it. So from that perspective, I'm asking you the question, more from an academics point of view, that what should we teach our students?
Understood.
If it is prescribed as two different schools of thought in the syllabus, so how do you go about describing the differences?
Right. So, according to me, actually, if you ask me, there are not lot of differences in NDT and Bobath. The main thing when I speak to the IBETA instructors and everything, what they say is NDT started with complete evidence based. It is build up on complete evidence from day one. Bobath approach initially was like the approach started evolving, and then they started working towards evidence. But lot of concepts, what they work towards is the same. So
Right.
ideally, if you ask me, I am not aware what you should say, tell your students about it. So we'll have to actually
Okay. I think it's high time to revise the syllabus accordingly then. So the students at least don't get
about the
confused.
bodies which are different, and they have their NDT body which is there and Bobath body, but the course
Hmm.
they
Core
conduct
remains the
are
same.
the same. Outline of the courses is the same, mainly in
Right.
adult.
Right. Right. I just have another
One
question.
says that if you do a basic course of NDT, you are
Hmm.
allowed to do an advanced adult course in
Okay.
Bobath. And if you do a basic course of Bobath, you are allowed to do a adult advanced NDT course. So
Right.
the outline is almost the same.
Okay, okay, okay. I just have another quick question with reference to assessment of motor control. Okay, the way we have key points of control as far as the treatment strategies and facilitations go. When you evaluate motor control or assess motor control according to Bobath, do you use the same key points of control as reference points?
So yes, so key points, we use key points as treatment distinct. In assessments, we absolutely follow the ICF model, which is used in Bobath as well as
Right.
motor control. Main thing about motor control is we follow the dynamic actions theory, where it says that it is very difficult to unlearn something if you learn it the wrong way. So if you actually learn something in a wrong manner, so we don't work towards allowing the compensatory strategies, because if you encourage the compensatory strategies from day one, then it will be very difficult for the patient to unlearn that and come to a normal strategy. So that is the main concept of motor control, what we use, dynamic action theory. So it is very specific that we insist on proper and means proper course of therapy when we are doing. Means we don't encourage compensation.
Hmm. Okay, okay, all right. I guess my time is up. So, Manisha ma'am, would you like to pitch in?
Dinesh, do we want to conclude the session now?
No, ma'am, I'll conclude the session. If you
Okay.
have any questions or discussion.
The discussion was very interesting. Zui madam has asked most of the queries which are with us, and at the end we can just take home message is that whatever concept you are using, basically rehabilitation of the patient and getting the independence and not letting him go into the compensatory pattern is the like what is the take home message which I felt from today's uh, this lecture. And Dr. Gaurish, it was a very good presentation, and congratulations
Thank
for
you.
that.
Thank you.
Thank you, ma'am. It was a great lecture to hear you, sir. Sir, I have one question for you.
Yes.
So in NDT, we use goal attainment scale, that's gas. So is it the same scale, something to
Yes,
we
yes.
use in Bobath?
Of course, we use goal attainment scale. So where 0 is the goal, plus 1 plus 2 is when you overachieve, -1 -2 is when you underachieve. Yeah, we use the goal assessment scales in Bobath also. They actually can be used in almost all the neuro approaches. So we follow a lot of outcome measures depending on the patient. Goal attainment would be a easier way of using it, but we use other outcome measures for each patient, like a Burke's balance, trunk impairment, fugal Mayer's, all the outcome measures, so that we know what is our predicted outcome and the improvement in patients. Yeah, we use it.
Thank you, sir. So thank you, the panelists. Thank you, Jui ma'am. Thank you, Manisha ma'am. Thank you, Gauri sir, which is the really great, enlightening, and knowledgeable lecture, informative you have given. Thanks to all Physio TV members. Thanks to Dr. Ashok Sham sir, Mr. Rahul Chobe sir, Dr. Apurva Simpi sir, Dr. Sona Polke ma'am, Dr. Neeraj Atavale sir, Dr. Manish Ray, and thanks to all viewers of Physio TV. I conclude that the session. Thank you, sir.
Thank you.
Thank
It
you,
was a
Dinesh.
pleasure. Thank
Thank you, Gaurish.
Thank you. Thank you very much. Thank you all.
thank you.